Chapter 41. Antimycobacterial drugs. Overview. Mycobacteria are odd-shaped aerobic bacilli that multiply slowly, every 18 to 24 hours in vitro. Their cell walls contain mycolic acids, which give their genus its name. Mycolic acids are very long-chain, beta-hydroxylated fatty acids. Mycobacteria produce highly lipophilic cell walls that stain poorly with gram stain. Once stained, the bacilli are not decolorized easily by acidified organic solvents. Hence, the organisms are called acid-fast bacilli. Mycobacterial infections classically result in the formation of slow-growing, granulomatous lesions that cause tissue destruction anywhere in the body. Mycobacterium tuberculosis can cause latent tuberculosis infection, LTBI, and the disease known as tuberculosis, TB. Note, in LTBI, the patient is infected with Mycobacterium tuberculosis but does not have any signs or symptoms of active TB disease. TB is the leading infectious cause of death worldwide, and over 2 billion people already have been infected. Roughly 10 million are in the United States. Increasing in frequency are diseases caused by non-tuberculosis mycobacteria, NTM. These species include Mycobacterium avium intracellular, Mycobacterium chileni, Mycobacterium abscessus, Mycobacterium kansasi, and Mycobacterium fortuatum. Finally, Mycobacterium leprae causes leprosy. TB treatment generally includes 4 first-line drugs, Figure 41.1. Second-line drugs are typically less effective, more toxic, and less extensively studied. They are used for patients who cannot tolerate the first-line drugs or who are infected with resistant TB. No drugs are specifically developed for NTM infections. Macrolides, rifamycins, and aminoglycosides are frequently included, but NTM regimens vary widely by organism. 2. Chemotherapy for tuberculosis. Mycobacterium tuberculosis is slow-growing and requires treatment for months to years. LTBI can be treated for 9 months with Isoniazid, INH, monotherapy or with 12 once-weekly doses of INH, 900 mg, and rifampicin, 900 mg. In contrast, active TB disease must be treated with several drugs. Treatment for drug-susceptible TB lasts for at least 6 months, while treatment of multi-drug-resistant TB, MDR-TB, typically lasts for about 2 years. Drugs used to treat first-line tuberculosis. 1. Etambutol, myambutol. 2. Isoniazid. 3. Pyrazinamide. 4. Rifabutin, mycobutin. 5. Rifampicin, priftin. 6. Rifampin, rifadin. Drugs used to treat tuberculosis. Second line. 1. Aminoglycosides. 2. Aminosalicylic acid, PACER. 3. Carbamazepine, Capostat. 4. Cycloserine, Ceramycin. 5. Ethanamide, Tricata. 6. Fluoroquinolones. 7. Macrolides. 8. Bedaquiline Serturo. Drugs used to treat leprosy. 1. Clofazimine, Lanprine. 2. Dapsone. 3. Rifampin, rifampicin, rifadin. Strategies for addressing drug resistance. Populations of Mycobacterium tuberculosis contain small numbers of organisms that are naturally resistant to a particular drug. under selective pressure from inadequate treatment, especially from immunotherapy, these resistant TB can emerge as the dominant population. Figure 41.2 shows that resistance develops rapidly in patients given only streptomycin. Multi-drug therapy is employed to suppress these resistant organisms. The first-line drugs Isoniazid, rifampin, etambutol, and pyrazinamide are preferred because of their high efficacy and acceptable incidence of toxicity. Rifabutin or rifapentine may replace rifampin under certain circumstances. Active disease always requires treatment with multi-drug regimens, and preferably 3 or more drugs, with proven in vitro activity against the isolate. Although clinical improvement can occur in the first several weeks of treatment, therapy is continued much longer to eradicate persistent organisms and to prevent relapse. Standard short-course chemotherapy for tuberculosis includes Isoniazid, rifampin, etambutol, and pyrazinamide for 2 months, their intensive phase, followed by Isoniazid and rifampin for 4 months. The continuation phase, figure 41.3. Once susceptibility data are available, the drug regimen can be individually tailored. Second-line regimens for MDR-TB, TB resistant to at least Isoniazid and rifampin, normally include an aminoglycoside, streptomycin, kanamycin, or amikacin, or carbamycin, all injectable agents, a fluoroquinolone, typically levofloxacin or moxifloxacin, any first-line drugs that remain active, and 1 or more of the following, cycloserine, ethanamide, or p-aminosalicylic acid. For extensively drug-resistant TB, XDR-TB, clofazimine, linezolid, and other drugs may be employed empirically. Patient adherence can be low when multi-drug regimens last for 6 months or longer. One successful strategy for achieving better treatment completion rates is directly observed therapy, also known as DOT. Patients take their medications while being watched by a member of the healthcare team. DOT has been shown to decrease drug resistance and to improve cure rates. Most public health departments offer DOT services. Isoniazid. Isoniazid, along with rifampin, is one of the 2 most important TB drugs. 1. Mechanism of action. Isoniazid is a prodrug activated by a Mycobacterial catalase peroxidase, CATC. Isoniazid targets their enzymes acyl carrier protein reductase, INA, and beta-ketoacyl CP synthase, CASA, which are essential for the synthesis of mycolic acid. Inhibiting mycolic acid leads to a disruption in the bacterial cell wall. 2. Antibacterial spectrum. Isoniazid is specific for treatment of Mycobacterium tuberculosis, although Mycobacterium cancer may be susceptible at higher drug concentrations. Most NTM are resistant to INH. The drug is particularly effective against rapidly growing bacilli and is also active against intracellular organisms. 2. Chemotherapy for tuberculosis. 3. Resistance. Resistance follows chromosomal mutations, including 1. Mutation or deletion of CATC, producing mutants incapable of prodrug activation, 2. Varying mutations of the acyl carrier,